basket full of vitamins into a person who can assimilate, and they'll go right through. You must be able to assimilate. And the way you do that is by getting a nerve supply back. Okay. 3 to 12. So when we have a lot of numbers to play with, who do we give the benefit of the doubt to? The patient. If you have little numbers to work with, you always take the benefit. I mean when you're asking for how much time you need. So we say that he got this about when he was 12. So he's had it 60 years. How many neurological deficits are we going to give him for that? You don't know that? Does anybody know how many neurological deficits you get for 60 years of subluxation? You people never had no seminars before, huh? One deficit for each year. And how long does it take to correct one deficit? 1 month. So now he has 60 deficits for that one. Where are you going? Oh, okay. Okay, how old is that 6 cervical subluxation that Brian told you he had? Well, it started here, moved here, it's here, and it's up here, so we know it's down here. So it's at least 25. So we'd say at least 25 to 30 years. How many neurological deficits we're going to give him? Okay, now we've got 85 neurological deficits. What other vertebra is subluxated here? Guaranteed is subluxated, and I can tell you what position we'll find it subluxated into. The atlas. Now when the atlas is hooking onto the axis like that, what position would we suspect to find it's locked in? In flexion, absolutely. And it would be what type of an atlas? How would it be listed? Superior. If it's a superior atlas and we have a third cervical subluxation, then what else do we know about this person? What, Lori? Out of compensation. So we got a bushel of trouble. Now we have an atlas subluxation. How many years are we going to give him for that?
As long as he is old.
72 years old plus 85 gets us how much neurological deficits now? 157. This man is 72 years old. In our interview, what are we going to say to him? If we divide 157 by 12, this will tell us how many years it's going to take to get him feeling good. Now, I don't mean feeling good, but getting back to utopia, which we never can possibly do, but it would be 13 and a half years approximately. So what are we going to say to this man? He's 72 years old. If you come under my care, what can you expect? You are going to be under my care for the rest of your life. Probably one time per week, once I get you straightened out. Now, this was one of the most miraculous cases I ever done. In 3 months, he never had to take any more insulin. He never had to take any more blood pressure pills. He started golfing and bowling and living. And he dropped over dead one day when we went out to brush the snow off of his car at 78. We gave him 6 years of life. See? You know what our sign's going to say on our wall up there? Nirvana, where people who are merely existing begin to live again. See? That's what that means. You begin to live again. Nirvana means you want to live again. You want to be reincarnated. So before you die, we reincarnate you through chiropractic and give you your life back. This guy was in my office every Tuesday for the rest of his life. See? But I gave him his life back. Now, if I would have only knew how to adjust atlases at that time, but I didn't. At that time, we were not doing the atlas from the back, which he definitely needed. But look at his degeneration on the second picture. We're starting to clean it up a little tiny bit, aren't we? The joint spaces are starting to get a little better. You know, if I would go back, you know, people say, can you prove this? Yes, I have cases. I had one case that the arthritis cleared up overnight. It was like a miracle. I adjusted her one day, and next day, arthritis like that was gone. I had to re-x-ray it 3 times before I'd believe it. Now that was a true miracle. I think Oral Roberts was in my office that day. Or Jimmy Swaggart. I don't know. But I just couldn't believe the way her joint places cleared up. It was the only one I ever had like that, but I have had people that have cleaned up very, very good. But you know, to clean up stuff like this would take about 10 years probably, see, to get those joint spaces nice and clean again. But you definitely can get them clean again. The trouble is, patients won't listen, see. They won't listen as long. They don't realize the dangers. You know, I had a secretary. She smoked all of her life. I said, why don't you quit smoking? Don't you know how crazy that is? And on days it was 0, I wouldn't let them smoke even on the porch on my clinic. Then they'd go clear out in the yard. There they'd be. I said, you have to be out of your mind. Number one, to go outside and get smoking. Number two, to work for a guy that won't let you smoke. You know, if you want to smoke, they're bad. Well, you got to die from something. See? Then, one day when she was bowling, she passed out and found out she had an aneurysm. The MD said she'd quit smoking. You know when she quit? Yesterday. See? Because our voice means nothing to most people. We don't carry any weight. Tom Whitehorn used to be the dean of Columbia Chiropractic College, a good friend of mine. Smoked and smoked and smoked. I said, Tom, why don't you quit smoking? He took a heart attack. The MD said, quit smoking, quit smoking. People just don't understand. But you know, on the other hand, I would start smoking in the morning to prove that cigarettes don't cause cancer. And don't cause cancer. I have an uncle. He made homemade wine. You ever drink any of that Dago red wine? That stuff will take the worms out of you. And if you have a tape for it, you take some of that stuff and see if it don't come out of you. He smoked a cigar. He smoked pipes. You know when he died? At the age of 99.10. That's when he died. He ate his breakfast at 9 o'clock, and 11 o'clock he faded off into smoked all his life. They didn't give him lung cancer, but his wife died at 37 of lung cancer, and she never would have thought of putting a cigarette in her mouth. You know what causes lung cancer? Subluxation. Smoking don't cause it. But did all the Indians would have died of smoke cancer. You know, one day there, BJ was at a meeting, and some MD was giving a speech. And he said they had just found out what causes TB. You know, it's nice to have had BJ as a teacher. He told all these stories, and I remembered every one of them. And this MD stopped and said, we know what causes TB. Because people spit on the street. And BJ stuck up his hand. Guy said, what do you want? He said, Adam had TB. The guy said, how do you know Adam had TB? He said, because Adam was the first man who ever spit. The guy said, that's great. I think I'll use that in my next speech. BJ said, I won't. He said, why not? He said, because Adam did not have TB. He said, how do you know that Adam did not have TB when you just said he had TB? Well, there was no one here to spit before Adam. See? Now that's how BJ thought. He could come up with things like that. Things like that. Spitting on the street is pretty dirty, but it doesn't cause TB. See? And smoking doesn't cause cancer. Of course, I have a sign in my office that says, cancer cures smoking.
You got that in Florida.
Yeah. Then I have another one in my office, it's a monkey. And he's sitting there like this. And the saying says, we don't care what it is, you don't smoke in here. Then I have another one that says, if you're smoking, you better be on fire. Yes.
Why did you divide the number of neurological deficits by 12?
Because we gave you one neurological deficit for each year, see? Which means it takes 1 month to correct 1 year. So we take the number of deficits we have and divide it by 12, and that tells you how many years you need. Because it takes, and when you have 180, that's 185 months. So to find out how many years it's going to take, you divide it down by 12. You got that?
Yeah.
Now you've got to start figuring out something else. What type of vat atlas do we have here?
A superior.
Laura, tell him what type of atlas he has. It's sitting in there as a superior atlas, but it's an inferior lock. You know how she knows that's an inferior lock? Because last week I told her.
Yeah.
And she's remembered. That's great. But if we were measuring this, it would be probably about an 18. So measurements only tell you what it's sitting at, how it's locked. As a superior and inferior atlas, you'll have to go by motion. So an inferior locked atlas, the lock is between, I'll see how good she remembers, between what two things? An inferior subluxation, inferior atlas. Is locked between occiput and atlas. A superior plus or plus plus atlas is a lock between what? C2. You got that? A inferior atlas is a lock between occiput and atlas. And a superior superior plus is a lock between axis and atlas. Now we really don't know what type of atlas this is. It's set as a superior atlas. But why we're suspecting that it's probably going to be locked as an inferior atlas is which bone is it favoring? The posterior arch favors which bone? The occiput. So, if it was favoring the axis, then we would consider it probably being. But we really don't know till we do a motion study. Now, take a look at that. There's the post x-ray. We took the curve back to normal almost. What did the atlas do? If that atlas was going to compensate to the fifth cervical, what should it have done? The posterior arch should have dropped down. It didn't drop down. So we have a true inferior lock here. So when we flex this neck, Mike goes, what do we expect the flexion to look like?
I'm inferior.
Huh?
Inferior.
But what would we expect it to look like? I want the relationship between occiput, atlas, and axis.
It stays the same.
It would stay the same if the occiput
Right.
But if this opens up and this stays the same, then it would look as a perfect flex neck, wouldn't it? Would look like a perfect flex neck if we was only looking at the flex picture. But it's not a perfect flex neck, is it? Because the atlas was already up on the occiput to begin with. So we have to adjust this. Does anybody know how we would adjust this? Rich thinks he knows. How would we adjust it?
The back, go down.
Oh, you're going to come down on the top of the posterior arch. Is that what you're going to do? Like this, you mean? You're going to come down like that? Huh?
Oh, no.
What are you going to do?
The back.
Underneath it? You're going to do it this way? Huh? Let's see, I got him confused. What way you want to do it? Don't let me tell you. You got three choices here. Which way you want to do it? You want to come up underneath it? You want to go right on it? You want to come down on top of it? Who wants to come down on top of it?
I'll go right on it.
I would like to come down on top of it. That'd probably be the best way. But if you try coming down here with an instrument, this is where you'd end up. Right there. There is so much muscle right in here. Ligaments and tendons. That was our first idea. How do you want to come?
Straight in.
Yeah, straight in.
Feet out.
With the idea of moving so you want to rock this up on the condyles like that. Okay? That's the same kind. Yeah. You could do this patient setting up, pushing a lot of force onto the occiput to move it back on the end, and use a scissor type thing. So you have somebody pushing back on the head, at the same time you're tapping the posterior arch to separate the two of them. Because the occiput wants to come back and the atlas wants to go forward, so you use a scissor type move. Okay? Brian? What type of atlas do we have here?
I can't see above it, but it looks like it's.
You can't see above it? Well, I can see the posterior and the anterior tubercle.
Well, it looks like it's,
And the top of that line is cutting it right in half, like as if it was a line.
so.
Now, is this line up here parallel with the floor?
Yes, it is.
Is this the posterior arch?
Yes, it is.
Is this the anterior arch?
Yes, it is.
Well, couldn't we use that black line as a line cutting the atlas right in half?
Yeah,
Now, if we compared this to the floor, what angle do we have, Brian?
parallel.
So what type of atlas do we have here?
Inferior.
Boy, was that hard. It's like pulling teeth out of a chicken. You ever tried pulling teeth out of a chicken? Okay. Lynette, I like the sound of your voice. So, how old is this subluxation? 10 to 15 years yet, because there's arthritis on 2 vertebrae. Not bad, but it's there. And it's actually here and here. See? Ain't started up here yet. But you know, it looks like there's a little bit here and here, so she could have had some multiple accidents, who knows? But were they severe or not severe, Laura? The accidents. If they're 15 years old, is this a severe accident?
No.
Absolutely not. This is a type of accident that she might not even remember. Okay.
Good telling. That's
There you
right. Okay.
Is that atlas a subluxation inferior, or do you think it's a compensation inferior?
I would think compensation is
Compensation to what?
to the reverse.
Absolutely. Now, if we were just looking like I used to look, strictly as atlas axis, how would I be torquing that atlas?
Down.
No, no.
I'm sorry?
If I was going to torque it to correct it, how would I torque it?
Yeah, you covered.
Oh, I would? Okay, now if I torque it this way, I'm going to take it down this way.
Right, the bigger.
That's what you want me to do with it.
If you have the right dimensions.
Now listen to me very careful. And you're strictly an upper cervical man. You do not look at reverse curves. I'm telling you, just look at this atlas like a strictly upper cervical man would. How would you torque it to correct it? Down? You want that anterior arch to come down like this?
Right, so it's superior.
No, he just told you we have an inferior atlas. There it is right there, laying flat. It's supposed to be like this, ain't it?
Oh, that's weird. I thought we were talking about superior. No?
No. This atlas. We're talking about this atlas right here. Is that a superior atlas?
Yeah, I think so.
How could you think that?
Oh, it's closer to see through that.
No. Did you go to Sherman College?
I had to do.
You've been to Sherman College? And that's a superior atlas?
Yeah. Yeah.
That's a superior atlas.
According to the analysis package. Now back this up, right?
I'm not gonna back that up.
There ain't no college in the world that would teach that as a superior atlas.
If it's closer to C2, the posterior arch, or the posterior tubercle, it would be considered a superior atlas.
Well, I tell you, no wonder you kids don't know nothing.
What?
Depends.
What?
We have to be, we teach here, you have to be able to see the condyle, C1 articulation, so we can't see that.
Well, we could see at some grades, and this thing's off of, that slide must be out of sync somehow, I don't know.
Yeah, so from what he's saying, yeah, if you were just to look at the posterior arch, and close to C2, you would think it might be superior, like a, lock with C2. So for that reason, that's why they think it's superior. But what you're saying is,
But don't they measure here?
yeah,
Don't you measure it in relationship to the,
no.
to anything?
Skull line.
To the skull line, not to the hard.
Okay.
So it's different.
You don't measure to the hard palate here?
We do it to the skull line.
Oh, boy. I thought this school followed BJ's teachings. Oh, boo.
So
This is BJ's here. No, this isn't BJ's, this is mine. But BJ's, he measured the atlas in relationship to the hard palate. And the normal, under them conditions, don't you have a normal range here?
Yeah.
What are they?
4 degrees,
Yeah.
4 to 6.
Superior.
Wonder whose measurements those are.
I think it's probably Dr. Sherman.
The guys that, you might be guys that,
Perhaps you've heard of his work.
Well, Dr. Sherman was taught by BJ, and he must have changed it. That's like the religions.
It's not Gunstead.
No, it's not.
I don't know whose it is, but that, under all circumstances, if you took that down, okay, forgive me. I didn't know I was treading on sacred ground.
You know, the part of that analysis that always puzzled me was what if the occiput and atlas remains the same and C2 moves underneath it? So that would change that relationship between atlas and occiput and atlas and
Yeah,
C2
see,
spinous
you-
process.
See,
So
the reason
I
I
could
picked,
never figure that one out.
the reason I picked the floor is because it's a constant. Occiputs are not constant. Nasal septums are not constant. What was the other line I said? Huh? Hard palate.
Hard palate.
Oh, that's not constant. So I picked the floor. So when you look at the anterior tubercle, if it's running parallel with the floor, and so is the posterior tubercle, then you have a zero angle. Now, if this drops below level of the floor, you have a inferior minus. And if you go way up here, you have a superior plus plus, superior plus, superior. Inferior goes from 18 to 0, and below 0. See, I gave you something that everybody could look at the same way, with no questions. You look at that anterior tubercle, that anterior tubercle there, I would say is probably 1 or 2 degrees below level of the floor. Okay. See, no wonder sometimes you don't understand what I'm saying, because
But that was a compensation.
that was definitely a compensation, because there's the correction after one adjustment. We took that neck with one adjustment, and this girl never had another complaint from 1985 to 1990, nor did she ever have another adjustment or anything for 5 years. And see, this is the stuff that drives me nuts. When chiropractors would want somebody like that coming 3 times a week, forever. I did that from July 16th, August 16th to August 23rd. That's how long it took for me to do that. Now, at that time, I thought she was totally corrected, because I had structurally brought her back to she's a 22 and a half curve here. But I want to show you the fallacies of that thing. Because at that time, I still questioned, why are some of these like this and then some of them are like this? You know, you can get a 17 curve that's over here, and then you get a 17 curve that's nice like this. Now this is the one that you always took pride in. You always worried about this one. Now if we do a head loading on her, she still has a head loading of about 10 pounds. Now I want you to look at something. This is the educational line, right? Look what I did with the patient's line. I stopped the vertebra short, didn't I? You know why? Where does this line go?
Intersects.
We still have 2 lines, don't we? That's what you call cheating, a little bit. See? I wanted to show how good I did, so I picked the good part of the curve and drew a line. Because I didn't know what the hell to do with the rest of it. Now, if we have a kink like that, between axis and a third, I'll make you think now. And I want a hand raised on this. What do you think this picture would look like in flexion? Does anybody want to guess? Is the IVF going to open or stay closed? What do you think, Laura?
No open, but not a whole lot.
What do you think?
I'm gonna stay closed.
Who votes for it's going to open a little bit? Who thinks it's going to stay closed? If there's a kink there now, it's going to stay there. Okay, now let's look at something else. What is the mate to C2? T1. See that big hole? So I'm saying that I probably still had axis and T1 to adjust. Well, I know we had T1 to adjust. Because 5 years later, she showed up in my office, and I wasn't there. Now, of course, she wanted me, since she didn't. See, we have a system in our office. We go by colors. We used to have little red dots. I had a red dot, Dr. Garber had a blue dot, Dr. Wilson had an orange dot, Dr. Wayner had a green dot, Sister Michelle had a pink dot, and Karen Polisar had a purple dot. And we would put the dots on according to how the patients wanted us. Now, when I go out there and see this, see what we do in our office, we just pull the files and lay them. You're back here, guess what? You have a long wait.
In that situation, is there a lock between C1 and C2? The reason it doesn't
No,
open up?
the lock would be between axis and vertebrae.
Right, so then when you're flexing, why wouldn't that open between C1 and
Well, you don't know that. You don't know that. I would say that it's going to stay exactly the same that it is. This person, her flexion is going to look exactly like this. Because what's the lead vertebra of the spine? C2. And it's already kinking up and closed. It's closed as tight there as it should be on what? It's already an extension. So it's definitely not going to open up. And if it doesn't open up, very seldom does the atlas and occiput open up. So I would suspect on this patient, occiput, atlas, and axis is all locked along with T2. And yet I discharged her, and for 5 years she didn't have one pain. So that goes to show you how long it takes symptoms to manifest themselves. Okay, now in 1990 she came in with a sore shoulder.
I just want to ask you, was the graft normal for her after that?
Well, back then, if we were getting change in grafts, we were happy. And her graft changed nice. It would definitely change nice. See, because it might take a while for another pattern to develop. See, when you do that, I mean, you have to look at what type of job I did. Now, let's go back. I mean, you've got a house that looks like that, and I give you a house that looks like that. I mean, that's a phenomenal change. So making that much change, he might not get another reading for 2 months. You know, you wouldn't really know. Another pattern wouldn't develop that fast. There'd be so many good things happening from this, it would overshadow anything because that subluxation was so much worse than what we have left. Yes?
Well, if that's not going to open up on flexion, when she does flex her, is she going to have any flexion at all?
Oh, absolutely. She's going to flex great down here. Down to fifth, she's going to flex great.
But if C2 is...
And see, anyone who already has an axis is in trouble. That axis is flexed good. I mean, not the first dorsal. So that's going to let her go down. That's what keeps her from going down. If that first dorsal was locked in flexion, she'd really be in trouble. But very seldom the first dorsal is locked in flexion. They lock in extension, which would give her a good flexion. See, anytime you have a bad lock in flexion, that vertebra is going to go good in extension. Because it's already, in flexion, it's going to go good because it's already in flexion. Go back and look at this. Look at that. That's a flat lateral. her first dorsal is already flexed in there. So when I brought her back, I didn't bring the first dorsal back. I brought everything back from him. Look here, people. See the kink there? See? If she would just turned her head down, she'd have had a good flex neck, wouldn't she? But that's a flat lateral. Now, she must have had a 70-pound weight head there. Okay, but anyhow.
Why doesn't the Whitehorns angle show up on that one that much?
There's a Whitehorns angle here.
It looks like it's more of a negative.
It is a negative. But she has a big beak on the front of hers. If you were going to measure her axis, here's how you'd have to measure her. See, she don't have a square bottom.
Oh, okay.
If you don't have a square bottom, you would measure her atlas, her Whitehorns angle with the body.
Okay.
See? A lot of axes are malformed with a big beak on the front. When you have a big beak on the front, you're going to get false Whitehorns if you use the beak. You have to use the body.
You draw a line.
Draw a line through the main, like divide the body in half. The main part of the body, see, is what you'd have to do. The Whitehorns angle is really an angle that's really not important except for patient education. It used to be very important before we had flexion extension. It lost all of its importance once we started motion. Yeah, I just talk about it because it's there, but we don't use it at all. Okay, now, let's play Let's Pretend, and let's play it with you. Let's pretend that this patient came into your office in 1990 and said to you, I went to Dr. Pierce one time in 1985. I was real sick, and he adjusted my fifth cervical one time, and I've never had a problem since. What vertebra would the average chiropractor adjust without thinking twice about it? Absolutely. Absolutely, because that's how they think. And if they would have done that, they would have totally destroyed this girl. This girl came to my office, and in 1986, we devised a new way of reading the atlas where we adjusted from the back. So when they come back in the office in 1990, they took new x-rays of her, and the only thing that they could find wrong with her was a locked occiput, atlas, and axis. And that's what they adjusted for 2.5 months. Now, at the same time, I was in Japan doing some research. And at that time, I came up with the idea that first dorsals was some of the biggest trouble in the world. And here's how I come up with it. See, here's how you do something. I go to Japan, and they'll line up 200, 250 patients for me. All problem cases. Now, this guy who lines these up, he ranks right behind Kenny Guzik as one of my top guys. This guy has a visualizer, he has 230 tables, he has everything. So he knows how to correct fifth cervicals, he knows how to correct atlases, he knows how to correct all this stuff. I go, and he gives me 225 problem cases. He accumulates them. Now, when you start doing 225 new patients in a row, they're all new to me. And all the things that I taught him how to do are corrected, then what do I have to do?
Something else.
I have to find something new or I'm going to fail on them people. Well, the thing I noticed, and the only thing I noticed that they all had in common, is when we extended them, we had this great big hole right there. So I thought, why would that hole be there? Well, it's because that vertebra is posterior and it's not sliding forward like it should. So I said, Massa, we're going to do something different today. We're going to toggle first dorsals. And I started toggling them. 225. Brought them all back in a day later. Every one of them was showing improvement by dermathermograph and by symptomatic picture. So when I came back home, I was standing in my own office, and my son came back to talk to Dr. Garber. And he said, Dr. Garber, Terry's here. She come back with her MIR report. She does not want an adjustment. She's going to go have surgery in the morning. And she's a very good-looking young lady. I remember all the girls' names. The guys, I don't know your name. And you know what? I don't care. I know that's Ursula. I know this is Laura. I know that's Lori. I know that's Lynette. That's really the only 4 people in Israel I give a shit about.
You missed one.
Oh! I missed one. There's my missed life back there. I missed 5 of them. Other than that, the rest of you don't have to stay after school. These girls all need special education. Tonight they stay after school for 2 hours, the whole 5 of them. I said, Terry who is going for surgery? They said, Terry Gilmer. I said, oh, impossible. She can't go for surgery. They said, why not? I said, that means I'd have to take 2 slides out of my educational tray. And do you realize how hard it is to find 2 slides to put back in there? I mean, that means you have to bring the patient in. You got to take pictures. Then you got to bring the photographer in, and he got to do that. I said, no. Let me go see Terry. And as soon as I walked in the door, she says, oh, thank God you're back. I said, Terry, what's this shit? Now, this is how I talk to my patients. I mean, it's what I call bedside manner. I'm writing a book on it. What is this shit? You want to have surgery? Oh, Dr. Pierce, I don't want surgery. Can't you save me? I said, absolutely. Come with me. I took her back and visualized her. Big hole. Now see, if I'd have knew this stuff back in 1985, I would have corrected that big hole. But see, you go so far with what you have, and then you quit. And you say, oh. As soon as you get them feeling good, they want to feel better. You make them feel better, they want to feel best. There's no pleasing these ladies. Don't you know that? So, but I try. So I took her back and flexed her and extended, and sure enough, I went up and I wrapped it, just as hard as I could. And she got off the table and she said, the pain is gone. She said, why did they do that? I said, not their fault, not their fault. They were doing the last thing I taught them. I haven't taught them this yet. I just learned it. So she went home. And when she took her coat off, her husband said, my God, what happened to that bump on your back? What bump? What do you call that bump? What's his name? Dolliger's hump? It was gone. I have taken away so many Dolliger humps with that adjustment, it's unreal.
Yep.
That one right there. I took one off of an 81-year-old woman from New York. It was as big as a half of a football. Laid on her back like that. 81 years old. Took it away. Of course, Terry never got any surgery. That was 3 years ago, October 16th, that I adjusted her. And I just saw her the last time I was in Pittsburgh. No surgery. Now, the question is yours. What vertebra do you think they wanted to operate on? What disc?
This X-ray?
No, not the MRI. Told him to adjust. To operate on a disc. Which one do you think? Does anybody want to guess? C5.
5, 6.
Now, they wanted to operate on C5. Was that herniation there probably in 1985 when I adjusted her? Probably. But here's a note. I gave it to you yesterday, but I'll give it to you again. You can adjust a vertebra that's subluxated, even if there's a slipped disc there. But if that vertebra is adjusted and you go back and hit it again, guess what you'll do to that disc? You'll rupture it. Remember the guy I talked about in Ohio, the 6 cervical? The first time the chiropractor adjusted him. The second time he ruptured his disc. That chiropractor ruined his friend because he doesn't use instrumentation, he doesn't know when to adjust. That same chiropractor was also guilty of letting a little 9-year-old girl die because he pounded her for 18 months, 3 times a week. That's the story of Terry Gilmer. Living a happy, healthy life. Now here's a different type. What type of neck would this normally be called? What? If you have a neck that's less than a 17-centimeter curve, what would it be? It would be hyperlordotic. But is this truly a curve, or is it a curve and a straight line? And the two of them together give you an appearance of something that's less than 17. See, here's the 17 line. I'm trying to push it on her back. It's not there. Okay, let's see. I like these guys when their eyes look someplace else. They focus their eyes someplace else and they think I can't see. Hey guys, it's because you're looking to all, I'm looking at you. Okay. What vertebra do you think needs adjusted on this x-ray over here? And
C3.
C3, locked in what position?
Locked in extension.
Okay, what other vertebra, if you have a C3, what other vertebra do you suspect?
C6.
Well, no. I mean, that's one of the ones you can suspect,
Right.
but not this case. That patient never had that accident yet. C3 has another vertebra that's usually locked with it.
Well, Atlas should be inferior. It's not inferior.
Is it?
No.
The hell it ain't. If that posterior arch is not hanging up on that occiput, I kiss you. So I've got to look again because it better be up there. If it ain't, I'm going to change his picture. Is that Atlas up on kissing that occiput?
Yeah.
Then that means I don't have to kiss you.
Like that.
Line-wise, it is definitely a superior atlas, isn't it? But subluxation-wise, it is definitely an inferior lock. Okay. Now, we, at this time, our idea was to get everything in between the educational line and the patient's line. Did we do that? Yes. So I made a great structural change, didn't I? But the occiput, atlas, and third cervical steer in exactly the same position. But this atlas, which was superior plus, is now just superior. And I thought that I was home free. But all I did was make what type of change? I made a structural change. I didn't unlock any vertebra. Now, I'm going to tell you something about this patient. This patient has been with me 30-some years. Now, I want you to look at that neck real closely and tell me which vertebra I adjusted some 14 years ago. No, the atlas still needs adjusted. The third cervical still needs adjusted, so it certainly wasn't him. but there's something in there that should tell you what type of subluxation this woman had years before. And there a little tiny bit of arthritis down in here. She had a 6 cervical subluxation before. The first time I ever corrected this woman, I corrected her with PIs. The next time I corrected her, 6 years later, I corrected her with a 6 cervical. Then I didn't see her again till 1982, which was like 13 years after I corrected that. 3 years after I corrected the 6 cervical. And this is what she was. And I really, that time, to do this, I pushed the axis. I took the axis here because it was the easiest one to get on. And see, you have to understand how I was thinking. What I wanted to do was I wanted to get these vertebrae back in these 2 lines. So my first idea was to adjust the atlas from the back. So way back in 1982 or 83, I got an idea to adjust the atlas from the back. But then I didn't know how I would do that by hand, So then my idea was to adjust 3rd cervical by hand. The 3rd cervical is probably the smallest spinous of anyone. So then I settled for axis because it was the easiest to get on, and I figured that if I adjusted the axis from the back, then I could drag everything forward with it. So that's what I did. And it worked as far as making a structural change. But my very 2 ideas were really the ones I should have done. I should have done the atlas and the 3rd cervical because those 2 were locked. And I would have brought the curve back, but I probably unlocked them too. Now this woman, after that, she came into my office. She'd never have a big complaint. Oh, Dr. Pierce, I don't even know why I'm here, but since you're in town, and I'd find nothing to do. And then in 1986 is when I come up with adjusting the atlas a different way. And that's what she really needed.
That's an inferior atlas?
Yes. Okay, now let's look at this occiput atlas axis area. We definitely have it kinking up here, don't we? And the atlas is hanging on to the occiput, doesn't it? So we would suspect that in flexion, that atlas might hang on to the occiput. But here's why we don't go by expecting. When we adjusted for cervical, her occiput atlas axis became much better, didn't it? So this is a person whose atlas wasn't locked yet. Now look at the arthritis in this neck. It's hard to really tell where his subluxation started because he has arthritis between 4th and 5th, he has it between 5th and 6th, and he has it between 6th and 7th. And this one by far looks the worst. But on flexion extension studies, 4th was the one I adjusted. See? Now, you wonder why. Maybe he had a whiplash at 6th. Maybe he had another car accident, and that car accident unlocked 6th and locked its mate, 4th. See? So you really don't know. Because you're not with the patient all the time. But 4th is what I adjusted on him. But you see how his neck grew after I adjusted him? Go back. You can only see how many vertebrae. 1, 2, 3, 4, 5 and a half. Now you can see 1, 2, 3, 4, 5, 6, 7. You can see a vertebra and a half more. That means his shoulders drop down this much. after that adjustment. She's like this. Just drops down. I mean, the changes that you make are just absolutely phenomenal. Ursula, how old is this injury? What? Well, then how old is this injury, Ursula? If you don't see nothing, how old is it? You don't see nothing. So how old is it? Absolutely, it's 1 day old. This whiplash injury is 1 day old. Oh, I have one rule that I never told you about. Kenny, what is the main rule of chiropractic? Now, it's not the gross problem. What's my favorite saying? Don't look.
Yeah. Don't look for fly, shit, and pepper.
That's it. If it's not there, people, don't try to put it there. Look for some, that's where the gross rule comes from, see? I mean, you never find fly, shit, and pepper. You probably eat a lot of that stuff and don't know. See? Look for something that's really there. Okay, now what's really here? Okay, let's start right from the end there. Give me one thing that you want to do something about. One thing definite.
You want to have a big hole at C7.
C7, big hole. Okay, good enough. That's one problem. What do you say? Well, there's all kinds of things wrong there. Well, we want to bring the curve back, absolutely. But now he said C7 because of this big hole. He wants me to go down here and push this vertebra up in that hole. And that's right. This is a flat lateral, people. How is the spinous supposed to look on a flat lateral? A slit. A small slit. Like these ones up here. Well, none of them are any damn good, really. There ain't no good ones on here. These are all. Every one of these from here down are doing what? They're all what? They're all standing alone, every one of them. There is not two vertebrae there that are showing a similarity. They all stand alone. So any one of these vertebrae here could possibly be subluxated. C7 is definitely. What other one are we positive is? T1. Speak up, guys. I mean, I'm thinking you're not learning nothing. Don't be afraid to be yelled at. It's fun, isn't it, Jesse?
Oh, yeah.
I mean, it's like being beat with a whip, some chains on. Okay, Jesse, since you like to be beat, what other vertebrae's in trouble here?
6.
Okay, we'll let that one float. Brian,
Atlas.
why?
It's looks like it's cut in C2.
And
Then
we
it's
got
got a
Ponticus posticus.
Yeah.
Where else do we have a peculiar looking thing?
C2, C3.
Absolutely. We're our reverse curve here, and then what do we do here? We have a horrible kink right here. Okay, this IVF is closed as tight as it should be in extension, right? Okay, so how would we suspect C2 to be locked? We'd find it locked in flexion. Absolutely. Because we're not going to find it in extension because it's already closed. Okay, this is a medical x-ray and was taken in a hospital. Subluxation. Oh, about 4 inches there. How much does her head weigh? No, I'm not telling you. I'm talking to the young lady. What's your name so I can tell? Roberta. How could I forget that? Roberta. About 50 pounds her head weighs. Okay. Now, after 18 months,